Hello and welcome. My name is Jeffrey Anderson. I'm a professor in the Dalai Lama School of Public Health, and it's my pleasure to be the host for today's meeting. Before I start my remarks, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. For people online, I wish to say hello to the audience we have here in person at the Munk Center. Thank you all for coming. I wish to thank the Dalai Lama School of Public Health and the School of Cities, who are co-sponsors for today's event. And I wish to thank the Institute for Pandemics. You'll hear more about that in a few minutes, for bringing us together. So the Institute is a university-wide effort initially started by our Dean, Dean Brown at the Dalai Lama School of Public Health, supported ably by Zenita Herji and Nelson Lee, who is now the director of the Institute. And over the last year, it has brought together people across the university to work together. And I want to thank them for bringing us all together. You know, it's times like this, I've been at the University of Toronto for like 30 years, and it's times like this when I realize the real value of the University of Toronto. I spend too much time in my own corridor. I haven't spent enough time understanding this university, and it's a powerful, powerful institution. And the range of abilities and skills that we have across the university is probably unmatched, certainly in Canada and around the world. And it's delightful to be able to bring that together. So as I mentioned, I'm a professor. I've been here for 30 years, so you know it's the old dog. I'm going to give you a lecture to start, and I'm also going to end that lecture with a quiz. So be prepared for that. But after that, we're going to really try and open today's session up to hearing from everybody in the room and online about what we can do to make this initiative have real impact. So again, I'm going to go through some background materials at the beginning, set some context. What we have spent much of the time for today is going to be listening to people, first from our panelists, and Shauna Braille will moderate that discussion, and then from you, both from people online and from people in the room. So it really is an attempt to listen for direction. And I think the direction we're looking for is what this Institute is going to do, and in particular, what the Institute's theme on recovery is going to do over the next 3 years. We need to hear what we should be doing. And that's the purpose of today. So I'm just going to tell you a brief things about the Institute for Pandemics, just to set some context. This is taken from the materials that were written mostly by Nelson to bring people at the university together. And the goal of the Institute is to link, support, and coordinate researchers from across the university to do what we do best, which is to provide cutting-edge evidence and research. That's what universities are for. That's what I'm so proud of the University of Toronto for. So we bring as an asset the ability to produce cutting-edge research. In this case, the research is targeted. This is applied research. We really want to have an impact. We actually want to go out there and make the University of Toronto a knowledge nexus. We want to be able to inform and strengthen public policy. We want to be able to advocate for health equity, which is a really important theme, I think, for us as a group. And we want to be able to work with the public to engage them in this conversation, to try and deal with some of the misinformation that has been a real plague during this pandemic. The ambitions are big. We want to be a leader across the world. We want to have local effect, provincial effect, national effect, but we want to be international leaders. So what's our purpose today? So the purpose today is for us to listen to you. So we're going to try and provoke you to make some statements, but it is about listening. And the panelists are taking perspectives from different organizations outside the university, even though they have university positions. I've asked them to speak from their roles outside of the university. So we really want to be able to understand what the issues are. Shauna's going to lead us in a facilitated discussion. And then we're going to broaden the audience and take questions online from people here. And I will say this is just the start of the process. We want to engage communities as we go through. This is our first step. The Institute, I think, is not going to be announced officially till sometime in the early next month, but this is our first step in moving forward. So when I say we're looking for advice, I'm lied to you a bit, because we do have a bit of an idea of what we want to do. And I'm going to just spend a few minutes. This is the lecture part, so be ready. This is where the quiz is going to be. Is what are we supposed to be doing? What do we think the Institute and what do you think the recovery theme is particularly focused on? And there's words that I put in italics there, but I think what we want to do is talk about the broader negative health impacts of the pandemic. I'll explain all of these. That we want to focus on inequities, and that we want to inform a an equitable recovery. So I'm just going to spend a few seconds trying to capture some concepts around each one of those. What do I mean by the broad negative health impacts? I read an article this week in the New York Times about the patient that died not from COVID, but because of COVID. And it's an interesting distinction. I think what you want to think about here is, it's not the people that got infected with the SARS-CoV-2 virus, that they're important, but it's the impacts of people that lived through a pandemic and people whose lives were fundamentally changed. Each one of us in this room can tell a story about the last 26 months, about how their lives were changed, or lives of their loved ones, or there's so many narratives around it. I think, as Ezra Klein called it, an omni-crisis. Everybody lived through it, right? So those are the broader impacts. And, we can think of them in two quick classes. I won't lecture too much longer on this, but the idea that we all believe, at least people in public health believe, that the broader determinants of health, your social circumstance, your material circumstance, has incredible impacts on your health and on health inequities. And everybody in this room, I think, recognizes that the pandemic changed fundamentally a lot of those things. There were material and social circumstances for people. Schools were closed, jobs were lost, jobs were changed, families were disrupted. Those things have health impacts. We know they have health impacts. It's our job to measure them. The other one is a sort of more traditional notion that the pandemic interfered with care that we provide for other people in other conditions. So that's the other thing to think of. People didn't get their care for diabetes. John Sinnott, who is one of the postdoctors working here today, has done some wonderful work on how care for people with diabetes has declined over the last 2 years. We're just not taking care of people the way we should have or could have in the past. Okay, so that's the health impacts, but the negative health impacts. It's more than just the infection with COVID, it's the impact of COVID and the pandemic. This is another one that I think is really important, is that there's a distinction between measuring health inequalities. We are a measurement group. We are scientists. We're going to measure things, whether it's by a narrative or by data. That measuring inequalities is different than looking at inequities. Inequities is inequalities that we think are unjust and that we can do something about. So I think this is a nice lead in that what we're doing is research that's motivated towards action. If you're working on inequities, you're working about change. Like you want to focus on things that you think we can do something about. And I think that's a very important thing to keep in our minds. So there's the broader health impacts, the notion of health inequities. And this, I think, is the idea of informing recovery. I think the university can play an important role in generating evidence, but we need to find the audience. Who is going to use what we produce, right? So we need to inform policymakers, we need to inform agencies, but we also need to inform the public. And I think that's a really important piece of this, is trying to find out how we can make the research relevant and applicable to a broad audience. And that is a real challenge. Like, researchers, normally when I'm in my corridor, I'm generating my research ideas. When we really want to do stuff that's impactful, we need to think about what our audience, what the consumer of evidence needs to know and what they want to know. So what does listening for direction mean? It means we are committed from the outset to trying to figure out what type of research, how we can make best use of those University of Toronto assets, how we can bring people who do cutting edge research to the table to work together to provide meaningful information to inform what we're going to do around recovery. Now, today we started, as I mentioned, with people who we can get to attend and people online, mostly drawn from the university audience. We are totally committed to broadening that engagement with the public. This is our first step in getting there. We want to hear today how we can do that, how we can engage the broader audience. Okay, this is the quiz. I promise you the quiz. Here's the quiz. Here's what we want to get from the audience today. If we're going to be in the business of measuring things, what should we measure? What are the topics and areas where measurement and evidence are important? And then the other piece of that is, what interventions do we think can work? How can we learn about what works? And how can we spread what works? Those are really important questions. So we want to get from the audience, what are the things that you think are priorities, and what do you think works and should be tested? And again, I think the second piece that we want to get out of the audience today is strategies to engage communities, particularly equity deserving communities. Which communities do you think we should approach? Which voices need to be heard, and how do we engage with them? This is, I think, a crucial step in this whole thing, and is the focus of what we're here today for. So let me tell you about how we're going to do that. The lecture is over now. What we're going to do. So I think what we've tried to do is provoke you. We hope to provoke you and get you to start to think of some questions by having a panel that we have brought together that we think represents different perspectives of this problem. Some of the people on the panel do have university affiliations, but we're asking them to speak from their other perspectives. And obviously some of the other people don't have those perspectives. We have four, I think, brilliant speakers. I've had a chance to interact with them over the last week. I've learned so much in that interaction that I'm thankful to each and every one of them. So the idea is that we're going to start with Beverly Esu, who, as I mentioned, I think earlier, has done some wonderful work at the global level, thinking about the impacts of COVID and COVID containment. So that's sort of the global picture. And then we're going to have Daniele Zanate, who's the president and CEO of the United Way, talk about how NGOs, that other sector that we don't really think about enough, I don't think at the university, about what they're thinking about recovery. We're then going to move to the provincial agency that we all spend a lot of time hearing from through the pandemic in Ontario, Public Health Ontario, what they're thinking about in recovery. And last, we're going to hear from someone who actually provides frontline care to people and is going to talk to us about her experience during the pandemic. So each of these speakers is going to come to the front of the podium. They're going to talk for a few minutes. When they finish, the next speaker will come up. And then what we're going to do is have Shauna start with a facilitated discussion with them. And then once that is done, we hope we've got the juices flowing both in the audience here and the audience online to provide those questions and comments that we need if we're going to have any impact with these wonderful resources that we think we have made available at the University of Toronto. So with that, I shall turn it over to Beverly Esu.
I'm learning to go on and off a mask with lipstick on. So if it's all over my face, maybe that'll make this even more exciting. So hello, everyone. It's my delight to be here. Now I want to stay very close to time so I can be respectful of my co-panelists. So I've prepared notes. So I'm delighted to have the opportunity to join you here in person, and a warm welcome to the folks who are joining us online as we are embarking on this important discussion to inform the development of a research agenda for the Institute's recovery theme. I haven't progressed here. In the few minutes that I have available, I want to frame this discussion with a challenge for us to view this as an opportunity to build forward stronger and more equitably, rather than building back to some version of what came before. This framing, I think, is really important because it ensures that we avoid falling back into our old ways of short-sighted planning, tinkering at the margins, grasping for low-hanging fruits, and looking for quick wins. I want to challenge us to prioritize intervention work that functions at structural and systemic issues. In designing the way forward, our vision of the health system that we want and the health system that we need to address current and future health needs of the population. I argue that we need to be bold. We need to be innovative, transformative, disruptive, and accountable, as well as uncomfortable, impatient, and frankly intolerant of the status quo. And why do I say this? I say this because the status quo, which has had a degree of inbuilt apathy, created blind spots in our planning and in our response to the pandemic. And it reflects a collective failure to anticipate and to mitigate the impact of some of the insidious and pervasive inequities that really predated the pandemic. So over the last 2 years, we have been confronted with data that magnified the ways in which risk of exposure was greater among racialized populations, and that was exacerbated by degree of marginalization. We had time and time again data on the impact of infection and outcomes that were disproportionately poor among equity-deserving populations. We know that the impact of the response measures were far worse among those groups who have been traditionally and historically been made vulnerable by systems that ostensibly were designed to promote and support health. And we know that our resource allocation decisions, both within our border and beyond our border, serve to exacerbate inequities and to compromise broader global health equity objectives. In fact, we're here today talking about COVID recovery planning when 1/3 of the world's population has not yet been vaccinated, and less than 20% of people in low-income countries have received their very first dose. So our route to recovery has to be mindful that our resource allocation decisions have impacts beyond our borders, and that COVID has really shown us how interconnected this world is, including the impacts of our decision-making. So the hope here is that in witnessing and experiencing these inequities, it's become impossible to look away. And thus this propels us into action. And in the discussion that we'll have today, we really want to start to formulate and articulate a research agenda for recovery or towards recovery, one that leads us towards equity in what has been and really what is an inequitable and unjust world. So I am going to, I have 3 ideas that I want to put forward for discussion to start to stimulate how we think about the research agenda. And they really hang together around these 3 broad areas of focus. The first is that perspective matters. I think it is true that we all have a pandemic story and we all have experienced the pandemic in particular ways. But it is very true that there have been groups that have experienced it far worse than, say, how I have from my vantage point and the privilege that I hold. And so I'm making a call for centering representation and inclusion in our approaches to research, in how we articulate relevant and meaningful outcomes, as well as decision-making and leadership for health. Second, I believe we need to shift from a scarcity mindset to reframe expenditure for health as an investment in the society that we want, rather than the current frame that has narrowly viewed spending on healthcare as costly and unsustainable. And third, the overwhelming volume of data and calls for even more nuanced data presents a real opportunity to harness this data justice agenda, to be more intentional about data collection, and in being intentional about data collection and use will help us to redress inequities, and it will also help us to ensure that that we are able to learn from our systems and be responsive to the diversity of needs. So first, as one example of many that I could choose, here I'm highlighting a major limitation in the leadership model for health, globally as well as here in Canada. We have known for some time that healthcare is delivered by women and led by men. And in Canada, while we are slightly better in terms of gender parity in leadership, we have quite a way to go in ensuring that leadership actually reflects the diversity of our population. So why is this important? Well, it determines whose perspectives are valued, who is prioritized, what outcomes are considered meaningful, what issues are deemed relevant, how solutions are identified and prioritized. Leadership sets a tone and an agenda for what and who is valued. And changing this model will have impacts that reverberate across health systems as well as beyond. Second, Investment for health and well-being. Now, this is by no means a new concept. It anchors some of the frameworks that have been used by the World Bank and other organizations to support models of development assistance. And more recently, it's articulated within the manifesto that's proposed by the WHO Council on the Economics of Health for All that was established about a year or two ago. So at its core, when viewed as an investment, we define outcomes differently. They may not sit squarely within the health system. For example, equitable distributions, we might value equitable distributions in the responsibility for unpaid care in the home, or understanding how investment can change an investment in gender-based violence to narrow the gender wage gap, or actually meaningfully reducing the experience of racism within the system. Similarly, the investments required will not only focus on healthcare services, but rather on the conditions that promote and support health and well-being for us all. These are investments in public goods. This can feel uncomfortable because we don't set budgets in this way. That discomfort reflects the failure of our imagination rather than a true obstacle for change. And so we're starting to see examples of this in what it might entail through the WHO's Council on the Economics for All. The UN and Canada have stepped out with these plans, which are termed a feminist recovery plan, which really articulate a vision for investment in health and well-being that allows everyone to achieve their full capabilities. Finally, in the last minute that I have, data justice. What do I mean by this? The UN some time ago described us being in a data revolution, which is true. We can maximize this opportunity and its impact for a justice-forward agenda that centers the needs of diverse communities and meaningfully addresses this paradox that made vulnerable communities face growing inequities and inequalities while being overrepresented in our health data. Global guidance on health data governance was released earlier this month and is now endorsed by many global institutions. And it articulates principles for data justice that will serve to protect people and their data, promote health value, and prioritize equity. We have examples to work from here in Canada with the First Nations principles of OCAP, as well as thought leadership on the collection and use of race-based data and for tracking COVID that came through the pandemic. Through a data justice agenda, we can operationalize principles of inclusion. We can be more intentional in data collection and use it to redress inequities. So I'm going to end here. I want to encourage you as we continue to listen to the other speakers to think about your own research and the questions and interventions that align to these key foci. And I'll leave it there.
Thank you. 3 things from United Way, friends. Number 1, we are who we are with and where we are with them. Number 2, get more towels and somebody get their hands on the main water valve. And number 3, it's going to take as long to walk out of the forest as it did to walk in. Thank you. Have a great afternoon. No, seriously. Rada lives in an illegal basement apartment in Rexdale with her mom. It's actually a hole in the ground, partitioned with 4 other residents. Her mom juggles 3 jobs, 2 part-time PSW gigs, and a factory job in Vaughan from 4 to 10 every single day. Contracted COVID after their 4th outbreak, hospitalized after 3 days, died in a week. Rada alone in Rexdale. One of the neighborhoods on the GTA COVID hotspot map. The same map, same neighborhoods as those with sticky, stubborn poverty. Same map, same neighborhoods as those with the highest proportion of racialized, precariously employed, underhoused frontline workers. Maybe the same map, same neighborhoods as those accessing emergency services, chronic diseases, and mortality rates. Rada alone in Rexdale, no family, until a local resident who was hired as a community ambassador by the local United Way community table, heard about Radha's mom's passing, knocked on her basement door, connected her to the Rexdale hub for food, slipped her the number of the 24/7 distress line so she could get through far too many dark nights and into the early morning, hired Radha as a community ambassador, knocking on doors in Rexdale to engage residents in Urdu, Punjabi, and Hindi and get them out to pop-up vaccine clinics or mobile vaccine clinics or an isolation center because they couldn't isolate in their one-bedroom apartment with 10 other people. And at every stop, Radha telling people, showing and living that we are who we are with and where we are with them. People matter, but increasingly place matters. In neighborhoods often forgotten by research and the headlines, community saves. This community ambassador model that we piloted in Rexdale was then scaled with Ontario Health into Brampton and other COVID hotspots across the province, because it demonstrates that community can meet basic needs and improve social conditions. So little Daniele, growing up, my parents both had 2 jobs. Every morning at 7 o'clock, they would leave me on the veranda for my Uncle Frank to drive up in the Pontiac Parisian. He was a janitor at the Toronto District School Board by night. He was a handyman at some low-rise buildings in the day. He was my childcare, if you want to call it that, because at 7 a.m., I pop into the Pontiac Parisian. He's smoking a Rothman. There I am sitting sans seatbelt in the front seat, eating my healthy Italian breakfast, half a loaf of Italian bread full of Nutella, because Nutella is good for you. And we would drive up to the low-rise building at Keele and Lawrence. Miss Square runs out screaming, Frank, Frank, there's a flood, a flood. We run in, there's water everywhere on the floor. My Uncle Frank yells out, somebody get more towels and somebody get their hands on the main water valve. As soon as COVID hit, United Way provided flexible funding to our network of 300 agencies so they could do what the hell they needed to do in the community. Flexible, unrestricted funding. We flooded the GTA with emergency dollars for small grassroots agencies, hyper-local in Peel, Toronto, and York region. 60% of that funding went to groups that had never accessed United Way funding before. 90% went to equity deserving groups so small that they could reach out to people like Radha. This is the work that we need to continue to do to meet basic needs, throw towels on the immediate, and United Way creating these cluster tables so that communities could solve their local problems in place. In York region, a group of residents and agencies getting together to work with local developers and turn low-rise housing into permanent transitional homes for women and kids fleeing abuse. In Toronto, partnering with Parkdale residents, agencies, UHN, and the city to turn a parking lot into modular housing units for people experiencing chronic homelessness with wraparound support, or hundreds of agencies coming together to lobby municipalities and the provincial government on paid sick leave and emergency leave for all employees, regardless of gig work or not. This is the immediate basic needs and hands on the system valves that underlie the root pressures we are facing together. More towels to absorb the now, and in the midst of it, trying to keep our collective hands on the main valves from wherever you sit, working not individually or institutionally, but in and with people in places in the community, knowing, as Indigenous wisdom tells us, that it is going to take as long to get out of this mess as it did to get into it. Decades of structural and systemic problems. And we at United Way are starting looking at ourselves in the mirror. Our board composition, our staff, and all of our policies. We're thinking about who we fund with a commitment that 25% of our funding must go to Indigenous and equity-led groups, not serving, because many of our agencies serve, but equity-led groups, and ensuring that 90% of the funding that we put into the community is unrestricted for community to decide what is best in their neighborhood and their place. Because from where United Way works, in and with community, dare I say, where each of you are individually and institutionally in research or in practice, there is no recovery, rebuild, reimagine, re-anything without acknowledging now more than ever that we are who we are with and where we are with them. Place matters. We will need to get more towels in the short term, but we've got to keep our hands, regardless of the silos we're in, on the main structural and systemic problems that underlie the water on the floor. And number three, with patience, perseverance, and persistence, we have got to take time, recognizing it's going to take a lot of work, starting with community, to get out of the inequality and inequities we are faced with, and only can we do it in a united way, lowercase. Thank you.
So good afternoon, everyone. I'm really honored to be part of this panel and have the opportunity to learn from my fellow panelists, as well as from everyone in this room and online. My goal today is to convince you that in order to build back better and fairer, the Institute for Pandemics should focus research on how the stars align. And I think that's kind of appropriate considering we're in an observatory. So what I mean by the stars aligning is that we need to strengthen the interface and the network of relationships between four components, stars, if you will. These are science, many of you in this room, practice, people like public health professionals, clinicians, policy, and people. And of course, when I say people, I mean communities and all of society. To convince you of the importance of this, I want to share 3 of my moments as a public health leader and professional from over the last 2+ years that I feel exemplify the importance of the science, policy, practice, people interface. And I believe that by focusing here where the stars are aligned, the most challenging, important, and impactful research questions will emerge and the path to implementation will open. So let me start by taking you back to Wednesday, March 11th, 2020, the date COVID-19 was declared a global public health emergency by the WHO. On March 11th, I was the medical officer of health for Peel Region, and I had announced the first case of COVID in the region the week before. And I was facing decisions to close municipal services such as childcare and recreation. And 2 days later was actually my last day with Peel before I headed to Public Health Ontario. And I stood with the mayors of Brampton, Caledon, and Mississauga, and with their support, we closed public municipal services, including childcare, for at least 3 weeks. I didn't take that decision lightly, and I appreciated the very significant impacts that would have on children, families, childcare workers, in particular, single parent families, people who didn't have an Uncle Frank to help look after them, and parents who didn't have jobs that they could take time off from. And I made that very difficult decision because we didn't know very much about COVID transmission at the time. We were seeing multiple cases in childcare. Hospitals were already starting to get concerned about capacity, and people were scared. At the time, we thought this was going to be a one-time temporary measure, but it wasn't. Between March 2020 and December 24th, 2021, there were more than 10,000 confirmed cases in licensed childcare settings and more than 2,000 licensed childcare settings that closed due to COVID-19 outbreaks. My experience is that we can often get good alignment between practice and political decision makers, and that's built over time on relationships that get born out of mutual interest. The science wasn't actually really that present at the time. It was still so early in the pandemic, we didn't know a lot. The key link that I believe continues to be missing is that with people and communities. And I still think that it was the right call at the time, but what I haven't seen happen is that in the 2 years since that time, we haven't evolved the supports and the ways to address the disproportionate burden of childcare closures to support health. And this is going to be important to address throughout recovery. Flash forward about a year to December 2020 and enter vaccines. We think the end of the pandemic is in sight, and it's just a matter of getting vaccines into arms. Overall, the COVID vaccine rollout has been a real success in Ontario. It's been a huge accomplishment, and I don't want to diminish that. Science developed the vaccines, policymakers were on board with the policies to get them to people, public health and other vaccine providers delivered them, and people accepted the vaccines. You know, we've had excellent uptake in Ontario. More than 82% of the population have received the primary series. However, if we start to dig a little bit deeper and we start to look at vaccine coverage with the Ontario Marginalization Index and look at material deprivation, we see a trend of lower coverage levels in the most deprived neighborhoods, and the trend appears to be increasing over time. And what we know is that those are the neighborhoods that had the highest risk of COVID. Those were the ones that experienced the most cases and the most severe outcomes. And while unlike the previous example, where the links to science and people were weaker, it kind of seems like the stars were all aligning around vaccination. However, in this case, I would argue that we need to expand how we look at the scope. Maybe it's just not one people star, but we need to look at a whole galaxy of people stars, and that all of these different groups, including those equity deserving populations, need to be linked closely to science, policy, and practice. It's been my experience that science, policy, and practice have developed in such a way that equity isn't built in as the default into everything we do. And so I think we have a lot of work to do through recovery to rebuild some of our structures to better support this, and certainly have the data in place to be able to make sure we're making progress. April 2022, our last leap forward in time. Cases are on the rise and the mask mandate's about to end. Masking has become a polarizing issue for society. 1 year prior, wearing masks was the norm. Almost everyone accepted that we needed to do it to protect each other and to protect ourselves. Less than a year later, we were watching anti-masking protests unfold in the nation's capital. Many of us felt strongly that it was too soon to end the masking mandates, especially in the context of ending other public health measures. The epidemiology at the time showed increasing cases, so the timing just didn't make sense. And as a population health intervention, the effectiveness of masking really is based on the degree to which it's implemented. It works better if we all do it. When not everyone does, those who are most disadvantaged are those who can't be vaccinated or those who can't mount an immune response. I also think it's important to keep in mind that the provincial pandemic response goal is to maintain hospital capacity. However, after 2 years, we have significant evidence of the real and significant impacts of long COVID. We also have healthcare workers, public health workforces, and other essential workers who are exhausted and challenged with the continuing work. And with this example, I think what we really see is the misalignment between science, policy, practice, and people. We're also starting to see fractures within those groups, such as people stars separating into distinct galaxies of masking and anti-masking. And I believe this demonstrates the importance of developing a better understanding of how people behave, whether that be decision-making that leads to provincial policy, or how we choose and when we choose to mask ourselves. And our ability to recover and prepare for the next pandemic would really benefit from a deeper understanding of barriers, facilitators, and mediators of behavior. So bringing it all together, these three examples that I've shared exemplify some of the challenges that I have seen arise at the interface of science, policy, practice, and people. And the challenges come when the stars aren't aligned. I believe that if we don't strengthen our knowledge and understanding of how to improve these networks of relationships that impact on decisions and behaviors, we are just going to get more of the same, which is, I think, why we're in this room. We don't want to see more of the same. So my challenge to all of us is, what can your discipline and expertise bring to support an effective network of relationships between science, policy, practice, and people? How will you engage with all of the other stars to develop your research questions and priorities for research? How will you involve the other stars on an ongoing basis as you move to implementation? COVID-19 has been the most challenging and humbling experience of my career. But rather than look down, I hope you will join me in looking up and helping the stars to align so that we can use research to build back better and fairer. Thank you.
Okay, so my turn. Thank you everyone for being here this afternoon, and I'm floored and honored to be following those three presentations. I think my role here is to give you some sense of an example of what we might be wanting to think about in terms of what a researcher might look at in terms of in terms of the priorities that we're thinking about. And so this is, quote unquote, my example from my perspective as a psychiatrist who works in a downtown Toronto teaching hospital that serves really people from across the province, and as a researcher who did some work over the course of this pandemic to really try and think about what was going on, and naturally lent itself to this idea of what kind of work do we need to do, what kind of evidence do we need to develop to get toward recovery. So think of this as whoops, oh, I'm so sorry. I'm not using my thing properly. Think of this as a case study where, I'm not necessarily saying this is the area or the population that we should focus on, but really more as an idea of how one might think about what kind of research we might be looking to do or we might be looking to fund, one of the types. So what's the issue? We've already heard a little bit today across actually all three of what the other presenters talked about the issue of parents. So as background, the postpartum period, the time after childbirth, is already a high-risk time for people to relapse if they have a history of mental illness or for them to have a new onset mental illness. And probably we're talking about up to 1 in 5 postpartum women and people are affected to some degree. And it can really be any kind of mental illnesses. You don't get a special kind of mental illness postpartum. You have depression, you have anxiety, you may have bipolar disorder, post-traumatic stress disorder, all sorts of things. But this is an interesting time because the mental health does not only affect a mother or a birthing person, but it also affects a developing fetus, a baby, and the family around. And so, early on during the COVID-19 pandemic, we were seeing reports in the media. We were seeing, we were seeing surveys that were being done across the country about mothers struggling with the daycare closures, with pregnant people having to go alone to their appointments, giving birth, being terrified of COVID, plus all of the other disruptions. And at Women's College Hospital, where I'm the head of the department, one of our major programs is called the Reproductive Life Stages Program, where we see a lot of pregnant and postpartum people with mental health issues. We started to see a skyrocketing number of referrals. I've worked in, Jeff was saying he's been around U of T for 30 years. I've actually been around U of T for 23 years, which is quite amazing. But I've never seen that. I mean, we were there was no way that we could keep up with this capacity. And yet at the same time, it was kind of anecdotal, like, okay, well, we're experiencing that. Is anybody else experiencing that? So one of the positive aspects that we've had around data in this pandemic has been our ability, at least in Ontario specifically, to look at some real-time healthcare data. And the community did come together to really, sometimes we'd be 6 months or 9 months behind in getting our health administrative data, but actually the ministry really worked on getting us data very, very quickly so that we could understand what was happening in real time. And so this allowed us to look at what was happening with postpartum mental health visit rates, comparing what would have happened if there was no pandemic to what was actually happening. And this is, you can see in this graph, you can see these blue lines going up and down and the red lines that go around them, which are just the error bars, and some dots. Everything to the left of the green line is before the pandemic. And so you can see that the visit rates were fairly stable. They change, we see fewer people in December, we see fewer people in the summer, they change along. And then after the green line, the blue and the red lines there, that's what we expected you would see if there was no pandemic. However, the black dots to the right of the green line are what the actual visit rates were. And you can see it's not even close. Like, you don't even need to do a statistical test here to see that what we experienced in our clinic at Women's College Hospital was happening throughout the province. And so we looked at a little bit more data, and you would not be surprised to hear that we were talking about increases in anxiety and related disorders and depressive disorders. Also, however, alcohol and substance use disorders, probably not surprised to hear that either. And I don't show it here, but even for severe mental illness, we saw slightly increased visit rates as well. We saw, not surprisingly, who was it in? So we tried to take a lens of, within that, not everyone is one and the same. Who are they in? Well, the people who had younger babies, so earlier in their 3 months postpartum. And then we thought, okay, well, we know that people who, for example, live in lower income areas may be disproportionately impacted by this pandemic. So we would be expecting that we would see higher visit rates, right? Actually, no. Especially at the beginning, we really didn't. If you look on the left, the top box is the lowest neighborhood income quintile, and then below them is the highest neighborhood income quintile. And the space between the dots that you see is how much space there was between what we observed and what we expected. And what you can see is that in the lowest income quintile, for several of the months, you didn't see as much of an elevation in visit rates. Oh, is it too small? You didn't see as much of a elevation in visit rates, and whereas you consistently did in the higher income quintile. So that makes us think, oh my goodness. So a lot of people were accessing care, but all these people who we expected would access more care actually weren't. And we could probably think about all the things we've heard today about maybe why not. Maybe they weren't doing well, but there are a lot of barriers in our health system for people to access care, and there are competing demands on their time. You're a single parent, you're working, you're a frontline PSW who's working 3 shifts. Like, when are you supposed to go to the doctor and get treatment for your mental health? I mean, come on, right? So, and that was just one of the disparities that we saw. And so I just wanted to show you that data because, yeah, we found higher visit rates. What we saw was consistent with, hypotheses about the potential impact. That early postpartum time, people were getting care, but there were some groups who might be expected to be the most impacted who didn't have visit elevations in the same way. And so, what are the potential implications for recovery? We have like a 26-month-long cohort of people who had babies and were affected. There's no way this won't have long-term consequences that we're going to need to think about for recovery. So we're going to have to think about, how do we monitor these maternal child outcomes, short, medium, long-term? What are the higher order consequences? And then we have to figure out what to do about it. So we had this huge transition to virtual care. We need to know about access care. Virtual care has been incredible, but there's also a digital divide. It's not going to work for everybody. What about the women who don't have a private space in their home or who can't take a break from work anyway? We need to be thinking really, really creatively about how we can get service to this population. And so, what this led to for us was we worked with, we invested. It was interesting what you were saying about investment. We actually used, hospital investment funds to create a new program that actually aligned with the quality of care that we should be delivering, where we developed a website that any person could access at any time of day, that if they needed more help, they could access one of our care coordinators, care navigators. They could log in, they could have a profile, and then the care navigator would help them with a personalized view of what community agencies were available, where could they get care, should they use some of the provincial systems, and then if needed, and if and only needed, they would then help engage with their primary care provider. Then if needed, on top of that, maybe then the psychiatrist would weigh in really if needed. We did a pilot trial that we're coming out with the results of, but we had 50 women in the pilot trial run through the intervention. You want to guess how many actually needed to talk to the psychiatrist? Of the 50? 2. Everybody else went through the care coordinator, they got connected with what they needed to get connected to, and we randomized them to those who got on the platform, had the care coordinator, and those who just got lists of resources. Well, guess what? Not surprisingly, the preliminary data suggests that the women who got this care coordination and what we call a stepped care intervention did a lot better than the women who were waiting. And this is just making sure that we restructured the system in a way that we could adhere to what the quality standards should be. We didn't even invent a new intervention. We're just trying to close the gaps between what we know and what we do. And I don't have much time left, but I can tell you that the process of engaging with diverse communities to realize that many different communities needed different things. They needed different things from our website, and they needed different resources. And it's complicated, but it's also encouraging. And I really took from that, maybe we do need to really, are we building back better, or are we like just building something new better that we know we should have built in the first place? So I will leave you. I did want to just acknowledge all the people who worked on that research with me, but I'll leave you with I'll leave you with that, and I hope that it was useful just to bring together a potential idea or illustration of how someone, a researcher, might be thinking about, what do we need to measure? What data do we need? What data are we missing? And how can we start moving toward intervention? So we should sit now, yeah?
Thank you very much, Beverly, Danielle, Jessica, Simone. Those were excellent, inspiring, insightful, and just mesmerizing presentations. I actually forgot that part of my job was to keep the time. But those of you who saw me motioning, thank you. We are going to begin our sort of discussion and more listening, and I am going to start off with 2 questions of our panelists, and then we will open it up to our in-person and online audience. If you are online, I will show some directions shortly, but if you have questions already that you would like to get out, you can just type them into the chat on the online system, and I will see them. So first question to our panelists, you each spoke about inequities, in many cases from different perspectives. And, for everyone participating today, it seems that so much attention has been paid to the concept of an equitable recovery already with respect to COVID-19. Why is equity such a difficult goal to reach? Like, why aren't we there yet? And how come, Danielle, it's going to take us so much longer?
because it's taken us decades to get into the mess. And I think we're so individually, institutionally structured that it is going to take layers and layers of work and allyship to work through it. And I think we've heard some of that here at the table. I think so many voices are so far from this webinar. They couldn't even fathom having a voice in what research might look like, how decisions are made, how do you access service, that we will have to build and recover at the pace of trust. And I think that's the momentum that we're going to have to keep. Do we have the patience to do that?
Thank you. Beverly, would you, I see you preparing.
I might add to that, so I think one of the challenges with equity is that it's become a term and a concept that means something a little different to everybody, right? And so, we write a grant application and we talk about it, addressing inequities, and depending on our disciplinary perspective, we're often meaning very different things, right? And so part of it is some alignment. I think also the development of methods to get there hasn't been enough of a convergence, enough of an interdisciplinary approach to working on issues. And so I see this as an opportunity to think about kind of an all hands on deck. How do we bring economics and clinicians and all of these folks together who have thought about equity in really particular ways to actually work together, bring those methods and the disciplinary perspectives together to actually advance. And I think the connection of the people we're trying to serve to defining the problem has been so vast as the disparity, I suppose, between their connection. And while we can work and feel that we understand the needs of community, until that voice has a role in setting the agenda, making demands on the data that are available and how those data are used, I mean, we're not really sort of making meaningful impact. So I think there's work to be done in terms of bringing that in.
Mom?
Sure, I can comment too. I mean, I think I would agree with Daniela that it takes time. And we talked about this concept a little bit in our pre-meeting, actually. At the CEO of our foundation at Women's talks about this as well, Jennifer Bernard, about centering on the margins. Like if we design things to be the most inclusive, to hear the voices of the people who it would be hardest to reach, for whom things are most complicated or difficult, who are the most, who are these, that we're terming equity deserving populations, then it's going to be okay for everybody else, right? I think Beverly, you had another way of putting it, but it's that concept, right, of centering not just in the mainstream. And that takes time, and it takes time to listen. And, I can tell you that intervention that I was talking about, we had a huge group of stakeholders who were there to give diverse perspectives. And sometimes those diverse perspectives are in conflict with each other. Sometimes they're, it's really complicated. It takes a lot of time to get to a place where you're using the right language, where you're inclusive, where people feel there's trust in using the intervention. And I think I do agree that we need to be very intentional, and we need to do this as quickly as possible. But there are some things that require time to build trust and to truly understand. So I don't think I've said anything either of you didn't say, but I guess I'm agreeing.
I'll build on the comments from the other panelists. So 3 things. So I agree very much with Bev. I don't think that there's a common understanding of what equity means. And that's going to be really important to have, especially for the recovery planning for the Institute, a common understanding of where we're headed. The second thing I think about is trade-offs and prioritization. So I think there's a general belief in the public that equity is a good thing. We want there to be equity. We want people to be supported. But when the rubber meets the road and we actually have to make hard decisions about priorities, resources, funding, That's where the trade-offs come into place. And what I see often happening is, we talk about, yeah, we want to do it, but we can't do it because we have to do this other thing. And it goes back to, I think, the nice points you raised, Bev, around thinking about health as an investment rather than, what are we losing because it's costing us to put into this. My third point is distributed responsibility and accountability. I think that this is a very challenging problem because there is no unifying responsibility or accountability. There's no one you can point to and say, this is your responsibility and you must do it. And we're holding someone's feet to the fire to make sure it gets done. And so it's very easy for that to get diluted. The flip side of it is, though, I think there's power in that, and that's something the United Way does extremely well, is how do you leverage everyone out there to contribute their small amount to this and actually be more than the sum of its parts?
Can I just say one very quick thing? Sorry.
Yes.
So while I agree that it can take time to do this work meaningfully, I think we do have to recognize that there are folks who have been doing this work for so long, right? So my slight concern is that if we set ourselves up to think this takes too long, that we don't have the evidence, when will we? When will we? And so how do we leverage the amazing work that has been happening? We do know what the problems are. We just haven't really factored in the process, the mechanisms to bring it in. So my call to be impatient is in part an impatience with my own community, my own, the academics in terms of waiting too long. Because I worry that politicians will, or not politicians, decision makers will hold to that and say, well, we don't know what to do yet. We don't have enough evidence. And I think there's an impatience among community, which I think is wonderful because with that groundswell comes a demand and an expectation for change.
Yeah, I would just add, I think it takes time to listen, but perfection is the enemy of good,
Exactly.
right? And we do know a lot. And so if we're measuring, I think that is something about thinking about the research priorities. Like if we're measuring something, we're measuring it for something to then hopefully take action on that. So yeah, it is that balance, right? Between we need to take enough time to listen and hear.
Okay. Thank you. I'm torn between which of my two questions to ask next. And I'm not going to do what I want to do, which is mush them together. But, Simone, you spoke very eloquently and you shared such a wonderful example about an intervention that just worked beautifully within the hospital context, within the mental health setting context, and that helped people so much using resources from the hospital. And as I think you said, not building something new, just improving upon what you already knew and had and were able to do. And so my question to others on the panel, and Simone, you can of course weigh in too, is what is another example of a successful, innovative approach to managing a public health challenge that emerged during COVID-19? I mean, we've seen so much innovation and creative thinking and creative approaches to addressing, and Danielle, you also talked about this. You talked about this in the context of sort of grassroots community, neighbor to neighbor. How can we build on these successes, and what sorts of new interventions might come out of this that the Institute for Pandemics can work on, can contribute to? Do you want me to tell you who should talk? Beverly.
Sure. Okay, I'll go first. I'll just leave this on because I'm worried what happens when I take it off. So look, I think there's been a lot written and spoken about the way in which the pandemic sort of propelled the use of virtual care. And so there's, I'm very mindful of the digital divide in that individuals' access and ability to actually benefit from virtual care has not been shared equally across the population. It's important to think about it distributionally. But on a whole, the idea that we won't go back, I think, is something that requires further study, and the ways in which virtual care can bridge some of the access divides, the way in which we can build on sort of the fundamental concept and overcome some of the other acceptability and access pieces that mean that there is still a barrier to its use. So I know, all of the work that took us to that point meant that it was ready to be deployed. And so I think there's something about that as a mechanism. I do a lot of thinking and work within the violence field, and very simple. And you spoke to this a little bit, Danielle. A very simple intervention of giving untied money to individuals who needed it. You know, aligned to basic income programs, which came out and then were scrapped. We're looking for them to represent value, but in fact, they allow people to actually provide for their basic needs. And there is now a wealth of evidence that's associated with ensuring that people have access to the means to be able to use the money to support some of those basic pieces, whether it's paying for transport to get to the service or daycare so that they can get to the mental health care that they need. Those very simple interventions actually were so effective during COVID. And so what about them allows us to scale, I think, would be two examples.
Maybe an example I'll give is, and I think it's really about how we've been working. There are many individual examples, but I think some of the things I've observed is increased collaboration across multiple disciplines, laser focus on what the outcome is. So things have moved at a far rapid pace than they have in the past. Things that would have taken, months to get legal agreements or privacy set up have gone at a pace. And so I think, we don't necessarily want to go back to the way we did things before. We don't want to push people to the edge the way we have during the pandemic either. But I think some of those things that we thought were barriers are not actually barriers. I think we've got a nice example of this from Public Health Ontario. We were asked to stand up very quickly a contact tracing program for the province and make all of the contact calls for public health units so they could focus on the working directly with cases. And, we didn't have all the staff to be able to do this. And we were very quickly able to get, within a matter of weeks, agreements with Statistics Canada, Department of National Defence, Health Canada, Ontario Health to staff this up to the point that over the course of the pandemic, we made over 1 million calls. We could do more than 6,000 a day. That is something that I could never have imagined doing in pre-pandemic times. It probably would have taken us more than a year to work through the legal agreements for that. So I think, those are the pieces that we need to try and hold on to, the silver linings that came out of the pandemic as we think about what can we implement through recovery to build back better.
Danielle?
Agree. I just want to, double down on the community ambassador model that the Toronto Star in the last week talked about as being one of the good news stories for the city. A real partnership between community, municipalities, public health, hospitals, Ontario Health, and then scaled. And, we often pilot well and then don't know how the hell to scale beyond. But that to me felt like the right continuum of trust. And I recognize for health and researchers and universities, community looks and acts like such a hot mess because it's just big and small and disconnected. But that in fact is a magic that we've got to harness. And how do you keep some of those pathways open for communication, I think will be the forward as we push ahead.
I'm going to open it up to questions now. And we're first going to take a question from the online audience and then from the floor. So if you'd like to ask a question after we answer this one, you can line up behind the microphone, please. But the first online question is from Blake Poland. And I think this ties in really nicely to the sort of community-based piece. He says, how do we do the necessary community-centered work to build back better? Or as Bev said, build better forward, which I like that a lot, with marginalized groups at the pace of trust in a way that doesn't further download responsibility to civil society. You can tell this question is written by an academic, but it's a great question. Thank you. Doesn't further download responsibility to civil society by, for example, a decontextualized celebration of heartwarming mutual aid, but instead focuses on the responsiveness of formal institutions to the needs and the aspirations of marginalized communities. I could summarize it one more time. I think essentially what Blake is getting at is how do we make sure that we have, that we engage marginalized communities without further drawing from their capital, asking them to work for free, asking them to work outside of formal institutions, and providing people who are engaging and supporting with a benefit for doing that and not asking them to just donate their time. Like, you can write on this and tell me if I've got that wrong.
I mean, I'll jump in just to say, you know, I'm trying to tie this back to maybe what we're doing in terms of the research priorities. And I guess, you know, what this whole conversation is making me think about is we want, like, why are we doing the research, right? We're doing the research to develop evidence so that then we can convince whoever, government, agencies, clinicians, whoever, to implement it, right? And so I think part of what Blake is bringing up is that, like, that's the kind of work we need to be doing. Like, those are the kinds of you know, interventions we need to be studying so that we can prove, like, that we can prove that those are the things that we should be doing. And maybe some of them, you know, I think part of what Beverly has said is, like, we already know a ton. So some of that research work is it's more implementation science work. It's more like, let's implement what we know we probably should be doing, and then let's have a framework to make sure that we're doing it properly, right? But I just, that's why I'm just drawing it back to that. Like, I think it's a big overall question, but I think maybe that is a research priority, that's kind of maybe one of the priorities that we should be thinking through as we move forward.
I mean, I'm glad that you use the language of implementation science, because that's where my mind went to as well, that there's a real need to be thinking about how implementation science, sort of as a discipline as well as a suite of methods, is a way to unify some of the work that happens within this particular theme. Because we spoke a little bit informally about pilots, and there's all of these great examples that happen around the place that, as an individual small community organization, you may not have the capacity or even the interest to think about what it means to scale that, but that it worked well with Brampton and could potentially work somewhere else across the province. How do we join that up so that we're not just funding these things in isolation? And so there is a role through, we see, you know, examples of small funding schemes that happen at the university and happen to some extent through some of the bigger funding organizations that really fund partnerships. So, you know, to really support implementation and research that bridge the community priorities with the research agenda. So that's part of it. I think an investment in comparative work, I think, is quite important so that we have the ability to understand and learn across, because while community and communities are very different and have different needs, there's some advantage in understanding the extent to which what was effective over here can be effective over there. And so I think that's important. And the last thing I'll say is, I felt through COVID, there was some recognition of a need to bring that voice into the formal structures for maybe not decision-making, but at least workshopping what the realm of possibility is. And so what does that mechanism look like? And how do we formalize some of that approach to inclusion? And when I say inclusion, it's sort of, I recognize we don't want to be burdensome on those who, you know, who have already experienced marginalization for many reasons. But what does a formal structure look like so that that voice is included in a meaningful way, not just tokenistically, and actually can feed through into a decision-making process? And I think there's work to understand, you know, our existing notions of policy, resource allocation and policy making. What is the structure through which participant voice and community can inform it?
Anything to add?
And doesn't further alienate or create mistrust. And we know we've seen examples of, I mean, the ultimate question is, what is it that only community can do? And so if you ask that very clearly, and part of that is defining the issues that impact them, like, then I think engaging them, listening, and maybe paying for their contributions to that work is important. But really, what is it that only research can do? What is it that only practitioners can do? What is it that only community can do? And we often get lost in that. So require clarity for sure.
Thank you. I would like to open it up to our in-person audience if we have questions in the room. Thank you.
Hi, I have a question. So Simone, in her remarks, briefly mentioned the digital divide. And I think that one of the things that the pandemic exposed, like nothing had exposed it ever before, was the digital divide. Because one of the greatest mitigation strategies we had during the pandemic was to go online. So billions of people around the world went online to work, to learn, to receive care, or to even not be isolated and just connect with family members. But if you take a global perspective, half of the world does not have access to the internet. And even if you look at countries like the US or Canada that have relatively high levels of access, the digital divide disproportionately impacts women, disproportionately impacts Indigenous communities, disproportionately impacts low-income communities. And even in large urban centers like Toronto, when we had to send, when all schools went to remote learning, and school boards were struggling to find laptops for students who didn't have access to that. So just wondering from the perspective of your comments on technology will play a very important role in recovery, in economic recovery, and how can we ensure that we have we apply an equity lens, equitable access lens? Because the reality is one of the things that the pandemic has done, while accelerating digitization on the one hand, it has actually increased that digital divide between those that have access and those that don't have access.
I don't mind taking this one first, as I've thought about this quite a bit. I mean, I think one of the things first from the frame is not to think about digital in healthcare for digital's sake, but think about what are the healthcare needs and then where can we use digital to help us. And so as a very specific example, some of the interventions that were developed and really took off at Women's during the pandemic were like asynchronous group therapy interventions that people could access 24/7, and they could post, and like therapists were posting asynchronously. And that was really helpful for some of those divide issues for people who didn't have a private space and who, you know, and who didn't, and or like who were at work, you know, during the normal time and stuff. And so that was that when we look at like the patient populations using that, those stuff, it's a different patient populations. At the same time, what stuff like that did was it actually virtual allowed us to be a little bit more efficient, especially when we did group therapies virtually, for example, or when patients would come for a lower amount of time, let's say, because, you know, if you just need to check on your medication, like you really only need 5 minutes, but if they were driving down and they were parking and, you know, you're not going to say 5 minutes, right? So it became more efficient. But what that also allowed us to do was actually open up some more capacity for people who did need to be seen in person, whether clinically or because of the digital divide issues. That doesn't solve the whole problem, right? It doesn't solve the fact that there's no Wi-Fi and coverage in certain areas of the country, right? It doesn't solve everything you're saying, but I think, I guess from my frame is like, if we think about what is, and I'm focusing on health because that's my area, so it's easier for me to give the example, but if we focus on what is the healthcare that is needed, and then where can we use digital to leverage it, that might help us get to the solutions of actually maybe some of the people who are in the digital divide. If we think about it in that opposite way, then we can actually maybe even get them on digital too, or make the space in the healthcare system so they get what they need, even if it's not digital.
I might just add to that. So I think there's been some writing that's come through the pandemic that's starting to frame access to technology as a public good. And so if it is a public good, the investment that's required to ensure it is available to other things that are public goods becomes different. And so how do we engage in a meaningful way with the private sector to ensure that we can bridge this divide? Because there's so many things about the pandemic that we will not look back to. So our use of technology has changed fundamentally through COVID, and the digital divide is very real, but the expectation for how we use and how we engage online will likely not go back to pre-pandemic levels. And so if digital infrastructure is framed as a necessity, as an entitlement in the way that many other things are. I think that can help to change the discussion around how we value it, the outcomes that are associated with it, and the investment that's required from whom and by whom to ensure that it's available. So I think that links to my argument around, thinking creatively in terms of what the case is to be made, to ensure it is accessible.
If I could add to that, I agree with you very much, Bev, that I think we need to think about this in terms of being essential, that everyone should have access to it. I mean, even if you think about the instrumental activities of daily living, like banking and that sort of thing, like you need technology to do that. And I think one of the challenges in COVID was the closure of libraries. So libraries are often a source of access to technology and access to free Wi-Fi that people who might not have it at home use. And so the idea of a library being an essential service and needing to remain open could be, a practical way to start to get at this. It doesn't fix every problem. We know there are communities that do not have areas where you can publicly access technology. But I think if we reframe it around the essential nature of the technology, there may be some actually like low-hanging fruit there to address this.
I think that's true. I also think though that the part of the digital divide is, and I see this with patients, right? Our patients who aren't, most of our patients who can use video are. The people who aren't, it's either because they're working all day, they don't have a private space, or actually because the complexity of their mental illness, or sometimes older people, like we also need to be thinking about like a coach to help people use the digital. Like if it's an interesting thing to, like if we're thinking about it as a public good, we also need the support to do it. Because using a banking app or all those other things, there's going to be inequity in the people who find that easy to do. So we can't just give it. We need to give it with the support around it.
I'm learning when to take my mask off, put it back on. It's like,
Sorry,
back
I
and forth. Sorry.
interrupted.
No. It's just me. It's just trying to figure it out. Yes to the question. Yes to all the panelists. And then where does it fit in the priorities of basic income? What the hell are we doing with Ontario disability pension? What about social assistance? Where does it fit vis-a-vis housing as a human right? And I don't think it's an either or. I think we have to think about these as investments, but there is a bit of an order. Like if I don't even have a house, or I don't have a good job with pay to stay home if I'm sick, or if I can barely survive, it's good to have the digital, but then what? So I think just trying to calibrate it all, given the fact that we're behind on a number of those building blocks.
I have one final question before we hand it back over to Jeff to close. And because we're short on time, it comes with a challenge. I'll tell you the challenge first and then the question. The challenge is you have to answer in one sentence or less. And the question is, so the IFP is intended to be an institutional strategic initiative bringing together faculty and researchers from across the university, as well as other partners. It will have 3 pillars, which I keep trying to remember, and they are readiness, recovery, and resilience. Now, here's the question. What needs to happen to ensure that the IFP successfully engages across disciplines, bringing together people from engineering, humanities, social work, management, global affairs, geography? One sentence or less.
The means is the end. Focus on the inclusion of people. The means is more important than the end result.
View this as an opportunity to work differently and sort of run towards that and be comfortable in the discomfort of not working in that way previously.
I'm going to be more concrete. I think it's if you build it, they will come. If we build it that way, that people need to partner together around a problem, then they will do so.
I'm probably more outside the academic sector than some of my other panelists. And so I'm going to change the question. And actually, I was thinking about how do you involve people from the community more, because, I'm a bit more outside. I think you should hire people from the community to actually be involved and do the work. And if you do that, the researchers will come.
Thank you. Thank you very much. Thank you to our excellent panelists. And let me turn it over to Jeff to conclude.
Well, first of all, excuse me, thank you all. I have built a career, whatever my career is, on working with people that are smarter than me and jumping on issues that I think other people have told me are important. I think this panel is a perfect example of bringing together really smart people to think about an idea together. And to me, it's kind of a microcosm of what we want to do with the Institute for Pandemics, is to start to engage people with very different visions who are eloquent to work together. And I think the other piece that came together for me today was the notion of the community, right? We have a community within the university which we need to repair, I think, to not repair, refresh, so that it wants to work together on a common problem. The common problem is recovery from the pandemic. The other piece that I think that we got the clear message from today is engaging with not just the policy community, which we're trying to do, but with the real communities, whether, and I think you said it so eloquently, it's the neighborhoods. It's all about where you live, and starting to think about how do we engage with those individual communities. And I will say that one of the things about the digital thing, it takes community away from being geographic and can actually make it online, right? Like we can get communities of people who are disparate, that have the same issues, but live in different places. So community can have a broader context than we've thought of before. My sense is that, you know, this is part of a process for us. And I have to say, the first time in 26 months I've been in a room where people can have a discussion and actually get something that's not on Zoom. We had that today, certainly in the front of this room. I think that's part of where we need to go with the Institute for Pandemics, is engaging in these more personal conversations about where exactly we want all those wonderful resources that the university can provide. And I'm going to harken back to that. The University of Toronto has amazing resources, amazingly smart people who all, not all, many of whom want to do this work. And if we can somehow generate with the Institute for Pandemics, and certainly around the recovery theme, a place where there is a nexus for us to work together and to engage the communities, that's where we need to go. And, you know, these are our first tiny steps to getting there. Today was a really important day for me, actually, because I spent most of my career working in my office. I rarely went out into the corridor, right? And now I'm starting to think about the whole community as a place that we can work. And I'm getting the sense from the people in this room, it's hard to judge what's going on online, though I will say the vast majority of people that started with us at 4:30 are still online, which is always a good signal to me, right? We did engage them. So I guess where I'm heading with it was first to thank everybody for their questions. We will certainly keep up. We keep our promise here. So the promise was that when we made this invitation, we're going to write a document that reflects what happened today. We're going to circulate the document to people who attended. And then I think we want to expand. I'm sort of getting a positive sign from Nelson and from Zanita. We want to expand the notion of community and engaging community in this, right? And that the next steps are to sort of build this agenda together. And part of it is a learning process for us about how to engage with our communities. So I know we're just coming up to the end. I really want to thank each one of you individually. You folks were brilliant. I want to thank the staff here at the Munk Center for making this possible. I want to thank the people online for your patience in staying online. And I hope you stay connected. I think we'll use this venue and this event to build a way to engage in more of these in the future. And again, the goal here, I think, is to take the assets, the rich and wonderful assets we have at the University of Toronto, and get them engaged in issues that are local, national, and international. And I think we have a chance to really do something that other places can't do. So again, thanks to everybody here.